you for joining us today for this session on health equity and social determinants of health. I'm Brad Love, a Grit Health co-founder and health outcomes researcher. And on behalf of the Grit team, I'd like to say we appreciate you being here this weekend and trust that you're being inspired and learning lots from our panelists and each other. We'll continue that growth opportunity now with a few remarkable colleagues who will introduce themselves momentarily. Quickly before kicking off with that, I'd like to remind you that there's a chat feature, probably down below, where we encourage you to discuss and post questions. Maybe just share where you're joining us from, and that would be a great part to get the dialogue going. Also, our goal for the session, in keeping with GVCC's mission of empowerment through education, connection, and advocacy, is for you to leave here more informed about the complexities of social factors in cancer journeys, and maybe ready to become an advocate or volunteer locally in your world. That being said, let's get to our generous panelists. Jason, may I ask you to introduce yourself and talk a little bit about the relevant programs you're working on?
Thank you, Brad, and thank you to everyone for having me today. Thrilled to see some fellow Rochesterians in the chat room. My name is Jason Dunn. I'm the Chief Operating Officer at Jordan Health. We are a federally qualified health center in Rochester, New York. We operate out of 9 locations, 8 in Rochester and 1 in Canandaigua. Our mission is to deliver the highest quality community-based healthcare to all with dignity and respect and without regard to ability to pay. As a federally qualified health center, we're a little bit unique among health centers in that all federally qualified health centers are governed by a board of directors that is comprised at least 51% of patients. So we have a very strong patient voice on our board. What we have learned as an organization over the years, and we trace ourselves back to 1904 from the early settlement house period, is that we cannot sit inside the 4 walls of our clinics. There is so much that is impacting health disparities across the city that we have to be actively engaged in the community. And a little bit later on, I'll talk a bit about some of those initiatives. Thank you, Brad.
Thank you very much for being here. Kim, could I ask you to introduce yourself and some of the work that you're doing?
Well, good afternoon, Brad and Grit Health. Thank you so much for having me. It's a pleasure to be here today. And to all those who are watching, my name is Dr. Kim Johnson. I am the Senior Director of the African American Health Equity Initiative at Susan G. Komen. The African American Health Equity Initiative exists and aims to decrease breast cancer disparities in the African American community by 25%, beginning in the United States metropolitan areas where those breast health inequities are greatest. So we're targeting 10 major US cities or metropolitan areas, and they are typically the usual suspects when you think about health disparities in this country. We're working in Memphis, St. Louis, Atlanta, Chicago, Houston, Dallas, Washington, DC, Virginia Beach, Virginia, Los Angeles, Philadelphia. And we have a myriad of programs we're doing in those particular cities where we're offering services such as patient navigation services to improve the retention and recruitment of African Americans in breast health prevention care and treatment services. We're offering low-cost and/or free genetic counseling and testing services. So it's always important to not only know your breast, but to know your risk for breast cancer. So we're trying to remove the barrier of being able to not know what your risk is. And so we're offering those services in cities, as well as we're working to improve the quality of breast cancer treatment, that would be oncology treatment, in our 10 metropolitan areas, as well as to improve the quality of treatment or the quality of screening in our metropolitan areas as well. So I'm delighted to be here, excited to have this discussion, and thank you for having me.
We're very fortunate, obviously, to have you both and appreciate each of your long-standing work in this space. If I could come back to you for one quick minute, Kim, just to start the conversation, I'd love to hear what it is based on your work that you'd like the audience to know about health inequities and social determinants of health?
I could take hours for your audience to know all the things that I think are important, but I really will try to boil it down. I really do want to raise the level of knowledge and understanding about what's happening in breast cancer in the Black community. And we are, in African Americans in this country, breast cancer is the second leading cause of death for African American women in the United States. And on average, we as Black women are 40% more likely to die of breast cancer than white women. We are diagnosed at later stages of the disease. We are often diagnosed with more aggressive forms of breast cancer, and when treatments are usually very limited, costly, and the prognosis for us tends to be poor. We are seeing this, and in a sense, Brad, it's a pandemic within its own self, and that not only is it happening, in the 10 metropolitan areas I listed, those are just the top 10, but it's happening across the country. And what it's important for viewers to know is that what we're finding from data we've collected and studies we've done is that when you think about health disparities, especially about breast health disparities, race and place really do matter. That we're working in those targeted cities because disparities are the highest. The question is why and what's driving those disparities? I think we'll talk a little bit more about that further in our conversation. But here's what's interesting. Recently, I was comparing the pandemic of COVID to what I'm calling our own pandemic of breast cancer in the Black community. And so many things that were similar in terms of the rates that are happening in the Black community. And what's interestingly enough is that in the cities that we're targeting for breast cancer disparities, it's those same cities, at least 7 out of those 10 have the highest rates for COVID too. And at the peak of COVID earlier in the year, that existed even more. Now, we're seeing a resurgence of COVID. I hope that's not true. What is unfortunate about that is that it wasn't surprising, because disease, as we know, tends to pick on those who are the most vulnerable and who have the least, regardless of what the disease is. So what we're seeing is that race and place matter. Like in one of our targeted cities, and I'm not here to shame city or name city at this point, but in one of our targeted cities, African American women are 70% more likely to die from breast cancer than white women. And it's because of their race and what happens to Black women in care and treatment. And it's because of what is happening where you live. And so we have a saying at Komen that where you live shouldn't determine whether you live. But unfortunately, as we're looking at these disparities, in many cases, it does.
Thank you. That's a powerful, sobering, obviously, introduction to the complexity of the topic. Jason, based on your experience, what would you like the audience to know about health inequities and social determinants of health?
I think Kim has made, as you said, Brad, a very powerful statement, focusing, as she rightly does, on breast cancer among Black women. Our experience, as she also said, is it extends to all chronic diseases, all life-threatening diseases. We were asked by Monroe County and the city of Rochester in March to respond to the COVID-19 clinic because thankfully our governments locally noted that there were inadequate supplies of testing and other treatment opportunities in the city. And we stood up a respiratory clinic in about a 2-week time period. No surprise, what we're seeing mirrors what we've all been hearing. The positivity rates in our clinic on a 7-day rolling average for African Americans tend to be 3 times the county's average as a whole. For Latinos and Latinas, it's about 2.5 times. And for white individuals, it's also, it's probably about 2.75 times the county average. The common thread through all of these is poverty. And that's one of the reasons why we're saying you can't get care totally inside the walls of a building. You got to get out, impact the community. And as we look at what's going on and why it's going on where it is, there is, as wonderful a city as Rochester is, there is a long-standing history of structural racism in the city. And if one were to look at a clock with the Genesee River splitting the city from 6 to 12 and divide into 4 quadrants, we're located in 3 of those quadrants, and it is known as the crescent of poverty. So one of the issues that we've been dealing with is looking at not just the symptoms or the manifestations of structural racism, but the underlying causes. And we are fortunate that there is an effort in the city around structural racism, a 21-day challenge where people can sign up and begin to look at their own perspectives. So the approach we're trying to take is looking both as individuals, what are the filters we bring every day, to how can we impact the community. One of the efforts that we're looking at is what we're calling a community health village that would bring into one physical location, because transportation is a key barrier for many of our patients, all the services, not just healthcare, but all the services that could potentially impact social determinants. And if I might, I'll tell you one short story that illustrates why we're going down this route. We had a young child, a toddler, who was suffering from severe asthma. And as much as our clinicians tried as best she could, and this was for this child, a young Black child, the asthma did not improve. Our community health workers went to visit that family and discovered that their apartment had black mold in pretty much every room. The landlord had refused to do a thing about it. We were able to connect them with legal aid, and they ended up moving before the landlord did anything. But it was an illustration to us that one of the social determinants is going to be housing. It is a critical piece. And if the housing stock is substandard, one needs to address that. And unfortunately, one of the means one has to go about is through the legal avenues. So as we look to the health village, one of the things we're going to bring in will be legal aid, located physically with all the other services. So if we see that again, we can refer our patient. Literally, the doctor can write a script, go get legal aid. It's right in the building. So we're looking at that. We're looking at a food pharmacy, because most of our communities live in food deserts. Those are the sorts of things that, as we look at social determinants, trying to address as many of the manifestations as we can, at the same time as going at the underlying core issue of structural racism.
Thank you for sharing that. And certainly, again, that's an incredibly powerful story, but really makes the point about the structural, systemic, and intertwined nature of so many of these problems that, as the chat is pointing out, so many of our attendees have unfortunately experienced personally. So it's wonderful in a way that we can have this dialogue to start helping and being part of solutions. I was wondering if I could follow up then a little bit, starting with you, Kim, about some of the structural issues that you mentioned, and ask you to share a little bit more deeply about some of the factors that drive these inequities.
So as Jason started and said too, the same holds true for breast cancer. Systemic racism or structural racism is, in my opinion, the chief driver of breast cancer health inequities that we're seeing in the Black community. And what stems from that systemic racism is, well, racism itself is a system itself. It's a system that, categorizes people based either on race, color, ethnicity, culture, and really does a good job, in my opinion, of differentiating those persons while unfairly advantaging some populations and disadvantaging others. And so when we're seeing it play out in the systems that are in our society, and it happens through unfair or unequal policies and practices within organizations, the healthcare system, for instance. And what it does is it leads to individual racial biases that exist. And so you're operating within a society or a system where that is designed to favor one without merit over another, and it does so. And so And so then individuals play a role within that. And so those are the main drivers. But we're also, the other drivers or disparities that we're seeing is the quality of cancer treatment is a disparity. It's one of the drivers, meaning all treatment is not equal, not created equally. And that's one of the drivers of all cancer disparities, not just breast cancer, we're within that too. And that screening services like genetic counseling and testing, are not offered at equal levels or standardized in all places and all facilities. It's not being offered to patients at the same rate. And we're finding that it's offered less to Black patients in some instances. And also things like we really do lack diversity in our clinical trials. When we're looking to make, looking to see then what are the best treatments for breast cancer, we don't have enough Black participants and other persons of color in our clinical trials to be able to get the best drugs and the best methodologies. Those are all kind of systemic things. I would say too, we're living in one of the richest countries in the world, but access to care is different depending on where you live. But also use of care is different too, of the healthcare system. Part of that is like person's own cultural beliefs, but I would also say largely inherent to the Black community, there still exists quite a bit of mistrust in the healthcare system. And it dates back to historical factors, Tuskegee studies, Anarcha, other sterilization practices that were done on Blacks earlier on, and I don't even mean hundreds of years ago, these studies existed. What happens is it perpetuates this era of mistrust. There is, of course, a genetic component to breast cancer that has nothing to do with the systems, but I can't ignore that. And like Jason was saying, there's the social and economic status that exists, and there are disparities in that. And we all know too, the social determinants of health are those non-medical factors like your transportation system, your access to fresh water and food, and your income level, your employment and education and things. All of those non-medical factors really become like the canvas that these inequities are painted upon, but it actually propagates the problem. And so when you have areas of the country where there are things like redlining, or where populations of color are kept from adequate services and things, and where you have issues where it's higher policing, or in some instances police brutality against certain populations that doesn't exist as high in other areas, it does impact the overall health of the Black community there, and thereby impacts then the overall health of the Black person with breast cancer. So, and yes, as Jason even said, there are food deserts in this country, where there are places where there's not adequate access to fresh vegetables and fruits and foods and things. And so all of this kind of builds this larger system that unfortunately results in these disparities, or really it's differences in then how people receive care, the care they receive, and then the factors that they have playing around them. It's a large topic that I'm trying to keep brief on, but it's like a whole lot to it. And I don't mean to paint it as just it's horrible, but at the same time, we'll get to, there's still some hope, and there's still some opportunity, because we wouldn't be here if they were not, to make changes to the things that we're seeing. We do have the ability to, make some changes, advocate for change, and to be those change agents. So I'm excited to talk about how we can get involved and things we can do as well.
Absolutely, and hugely appreciate that. As you're saying, it's not possible to offer a short summary of an incredibly complicated and powerful issue that just changes the demeanor of healthcare and cancer survivorship and who has access to what. I'd like to, before getting to wonderfully, thank you for the segue, Dr. Johnson, about getting to the change action bit. I'd like to give Jason a chance, based on his own experiences, to address the same topic and share what he would like us to know about the factors in his experience and research that drive these inequities.
Thanks, Brad. A couple of things. I did see a question pop up that I want to respond to as well. I do want to share a further thought on what Kim was saying about testing. Yes, that is a huge issue in terms of clinical trials and obtaining adequate numbers of people of color in the trials. And I've got a lot of grit for the work you're doing to help the communities of color understand the importance of participation and to get past what happened at Tuskegee and elsewhere. At our institution, our health center, we actually have a panel that if we are approached with a request for research, we are taking it to our patient members of our board and our quality assurance committee, and we're actually testing the test first. Is this research going to have a potentially positive impact for our community? Are there risks that perhaps shouldn't be undertaken because of the nature of the community? And making certain we have community input before we agree that yes, we'll work hand in hand with the organization. And I got to tell you, one of the downsides has been we've not seen a lot of research being done in the communities we serve because the communities still remain very wary of that research. The question that was posed was, what can one do in the days of COVID to volunteer? It is tough. We are, as many other organizations, we are limiting access to the buildings, trying to keep social distancing, trying to keep people safe. We're currently operating at only about 75% or so of our normal capacity. But one of the things that every one of us can be doing, and particularly members of communities of color, if we listen to what Kim was saying, one of the experiences we had around breast cancer imaging, and we do have in one of our sites a screening center, women are coming in late. That's, yes, there are two factors when we look at the late stage breast cancer that Black women often have. One is, are they getting the appropriate treatment when they are screened early on? The other that we're seeing is there's a reluctance to come in and be screened. And there's a social factor inside of the Black community, and I know Kim will tell me if I'm going on this here. Women in the Black community are the pillar of many of the families. We had a campaign where we had one of our board members participate, where the message in the campaign was, yes, your family needs you. So you need to take care of yourself. Come in and get screened. And we've had some success with that. What we have found is going out into the churches and getting the first ladies involved. The voice that encourages early screening must come from within the community. So for those of you who want to volunteer, my first suggestion is talk to friends and family. Highlight the critical importance of early testing. Highlight the critical importance of being an advocate for your own healthcare. And for those of you who may not have income, they may not be able to get regular care at the time, I would encourage you to look out to your nearest federally qualified health center. All federally qualified health centers are required by law to deliver care, and for those who don't have adequate funds, on a sliding fee. And Brad, I believe I sent you a couple of links, one to the National Association of Community Health Centers and one to the Health Resources Services Administration, both of which you can go on to. You can look for health centers in your community. And every health center, like Jordan Health, is dedicated to bringing the best possible care right into the community. So I would encourage you to do that. And then this, the complex, as Kim has pointed out, and as you pointed out, Brad, this is huge. And it is, from a meta perspective, an absolutely gigantic issue that appears to cry out for absolutely huge intervention. And no doubt there are a lot of us who are asking, well, what can I do? I'm one person. You can start by, as I said earlier, talking with family members and friends and encouraging getting preventive care, getting screening. and then look at what the needs are in the community. One of the programs in Rochester that a number of my colleagues participate in, they go into the public schools to read, to help youngsters with reading. Now, that's not a short-term issue. That's not a short-term solution. But frankly, the problem didn't happen overnight. And it's going to take perseverance and ongoing effort, even at a very personal level, to make change. The other thing I would suggest, and it's something that for those of you who are with companies, force your companies to look at its leadership. It's something we do every time we're recruiting. Do we have opportunities for members of communities of color to take on leadership roles? Because we're not going to change structural racism without moving capable individuals from all communities into positions of power and influence. So I would encourage everyone to look at their own companies and challenge leadership to make certain that there are opportunities, and not just from within the company, look into the community, develop mentorship programs with area schools to bring people of color into the organization. So some thoughts on both sort of the lower level and the larger level, how we go about this.
I appreciate that. Thank you for following up and starting wonderfully the prompt to our next question, which we had the benefit of Suhani setting us up for. So thank you very much for helping guide the conversation there, Suhani, and being here today. Kim, I'd like to pose the same to you, and this certainly will be the next key part of our dialogue because of the depth of it, to bring up some of the things people in attendance today can do about the challenges, to follow on your point earlier about the hopefulness and what actions people can take.
Well, I tell you, I could almost say ditto to what Jason just said, because he hit it from both a systems perspective and an individual perspective. What I will only add, and I agree with wholeheartedly with everything he said. So what I'll start with is the bigger picture, and then we'll work to like us as individuals. Health is one of the challenges that we're seeing is that when you look at challenges of health disparities, breast health disparities, or any other disease, a lot of the programs that currently exist are typically aimed at the patient and not at the system. So for instance, with breast cancer, of course, there is a need to educate women, Black women, about their own breast health. There currently actually is a need to encourage us as Black women to have clinical mammograms and to have a clinical breast exam, to learn our family history, and when needed, to have genetic counseling and testing services done within our families. That is clearly, I'd be a hypocrite if I didn't, advocate for all of those. Absolutely have to happen. But if we do all of that, and if we as Black women do our part, and we do everything I just said, and we still go to a broken system within the healthcare system, the problem is not solved. We're only addressing half the problem. And so what both this pandemic, breast cancer, and other things have shown us is that really there has to be changes in the systems, and especially within the healthcare system. We have to have a healthcare system and other systems that first acknowledge that this problem that exists, that it acknowledges that systemic racism does exist in public health, it does exist in healthcare, it does exist in the individual level, and there are differences between treatment and services that Blacks get and other populations get. One thing we can start by doing, and it's the group we're talking to today is unique, because normally I have to start with a speech on, we have to show some compassion and commitment. That's not the case for this group, because you're persons who are survived or patients themselves or caregivers. But I usually talk to people about not only being committed, but having some compassion, suffering alongside someone to take action to relieve the suffering of another. And that remains important. It's just that, how do we begin to see ourselves going from our role as patients, survivors, caregivers, to change agents, to begin to look at ourselves and say, we are a part of organizations. we lead in some capacity. You know, leadership doesn't mean necessarily you're the CEO of whatever company, or you're the head of Grid Health or whatever, and bless God if you are. But it's blooming where you're planted. It is doing the things that you can do within your own power. How could you see yourself making change? For some of you, it will be things like, I'm reading some of the chat. You're amening me, you're high-fiving me, you're flat out 100%ing me on some of the topics. Be willing to stand up and say those things to organizations in your area, whether it be when you visit your own private physician. And if they're not offering some of the tests and things I mentioned, ask for them. Demand them, you know, inquire as to why things are happening. When and if you encounter bias or racism in the system, confront it. Feel powerful enough, be empowered to know that you too can make a difference. If you are more of the type to advocate at local government levels, you know, being a part of different boards and, you know, within your communities, being a part of community-based organizations that work in this field, to add your voice. See, we need your voice to change this. Systems don't change unless there's a groundswell of community and activism that says we demand the change to happen. I would also agree with Jason, on the point that if you are in leadership, and I mean formal leadership in an organization, we do need more diversifying of leadership in organizations. It can't just be so homogenous that the people making decisions for their communities all look alike. Like our organizations need to look and represent our communities. I know specifically, for the project that I'm working on at Susan G. Komen, the African American Health Equity Initiative, we are just in those 10 cities for now, but there are some opportunities within those communities we're in to partner with organizations in those communities if you have a desire to work on this issue around breast cancer. I know from Komen headquarters, we will soon be launching in April of next year a patient navigation program that specifically trains persons in the community who want to be non-clinical patient navigators, meaning you want to help women, or men for that matter, who are in the Black community to learn more about their breast health. You want to help get them into screening through mammograms, help get them into the healthcare system if they're diagnosed. You want to play that role of shepherding or navigating persons in the Black community who are impacted by breast cancer. And we're going to be tapping into the faith-based community, and Jason mentioned first ladies in churches and other things in the community, because many of you have health ministries that do these types of things, or are primed to begin to do these types of things, because you already have the heart to do it. You already have the compassion and the commitment. There is going to be that opportunity to begin to partner with us if you are in one of those 10 cities, to get skills on core competencies and skills around how do you do this kind of lay navigation, you know, a little more formally in your community, and we'll train you for free. And we'll teach you some of the ins and outs also of breast cancer. And we're going to be doing some interesting modules directly aiming at the Black community in terms of how then can the navigators that we're going to train help to navigate women around or through or to deal with the systemic racism we're seeing in healthcare. So we're really building this with, for, and by Black women to do this in communities. That's one very tangible way that I know is coming out of national at headquarters at Komen. We, of course, have robust policy and advocacy work, and on our site is the Center for Public Policy and Advocacy exists there. We advocate and do policy work across the United States. There is something, you know, if you'd like to link up with us there as well, if you have that sort of interest, it's a very tangible way to link with us. I want to go back and say one last thing, and I'll give an email address that you could reach us for all of that. It's healthequity@komen.org. That's healthequity@komen.org. But I want to encourage you participants, and thank you for being a part of this. I know you have a desire to help. You have a desire to heal others. You have a desire to see change and make change. In order to do that effectively, I want to say this. It starts with taking care of yourself. Because if you burn yourself at both ends, then we won't have you either. And we need you. We need your voice. We need your compassion. We need your caring. We need the commitment that you so aptly demonstrated in all the work you've been doing. You've got to start too by taking care of yourself, by making sure you're doing the things that lead to your own breast health that really matter. That you're having your clinical exams, that you're, taking care of yourself, staying safe even in this pandemic, and that you're being a voice for your own care and your own treatment as well. And so and the Bible says, physician, heal yourself. Physician, take care of yourself. Those caregivers who want to help other people, it's important that you help yourself too.
I love it. Thank you for sharing all of that. And that really is just an amazing bit of wisdom and advice, and empowering, of course, as well, right? I put in the chat just kind of the way I frame that and try to share it, that especially for people in historically marginalized communities, self-care is a radical act in this modern world, because there's so many pressures to be doing other things, and taking that space can be exceptionally difficult. We've had the great fortune to have another panelist join us. Thank you very much, Claudia, for being available. And obviously you've been able to follow the last few minutes, but could I ask you to introduce yourself and the kind of work that you're doing at CHOC?
Yes, of course. Thank you so much for having me today. I apologize that I was not able to join sooner. My name is Claudia Begino. I am a social worker at Children's Hospital of Orange County in Southern California. I have been at CHOC for almost 13 years. It'll be my 13-year anniversary this month. I've been in a supervisory role the last 2 years. We're looking at things like readmission, telehealth, finally social determinants of health, right? As a social worker, I want to say, where was everybody? Why did you guys get so late to the conversation? Because as a social worker, that's kind of what we do. We look at people from a systems perspective and look at everything that can impact a cancer journey, for example. But where my passion lied and will always lie is in oncology. I was a pediatric oncology social worker for 11 years, and I helped families with emotional support and resources. And I think it's just incredible to always have these opportunities to join conversations like this. I can definitely remember a lot of the families that I worked with and how social determinants of health can impact their cancer journey.
I appreciate that. Thank you for making time to join us today. Could I ask you to follow up a little bit on that and share the kind of work related to social inequities and social determinants of health that you had been doing, and your powerful experiences as a practitioner?
Yes, of course. When I think about social determinants of health, there's one particular family that comes to mind. I had the pleasure of working with only Spanish-speaking families. I am bicultural, I am bilingual. I grew up in Santa Ana, which is one of the cities that we work with, where 25% of our population lives in poverty. After San Francisco, Santa Ana is like the second most densely populated city in the entire state of California. So if people can think about that for a little bit, and how we have such a need in such a small area. And most of the families that I worked with came from Santa Ana. So one particular mom, a single Latina mom in her 40s, 3 children, low literacy, low income, very limited network of support, relied heavily on friends, neighbors, didn't have a lot of family members in the area. Her middle child, who was about 10, I think, was diagnosed with acute lymphoblastic leukemia, also had Down syndrome. So this mom had every struggle up against her, and somehow was able to get her son through the majority of the beginning of that treatment, which is very intense, as many people know. And we reached a point where she was coming only monthly to her follow-up appointments and twice a month for labs. And the team reached out to me and said, Claudia, we haven't heard from this family. We're really concerned that this could be a case of medical neglect. And as a social worker, I immediately think, oh, great, now I'm going to have to file a child abuse report based on medical neglect. But I knew, because of the rapport that I had with this family, that something else was happening, something else was going on. So I tried calling her, had no success, and finally thought about, okay, this child is back in school. Let me reach out to the school. Let me reach out to the school nurse. School nurse had also mentioned that he hadn't been coming to school, that he hadn't been feeling well. And I thought, oh dear, I hope he's not septic, but what's going on with his family? So the school nurse was able to send out a liaison to do a home visit, and they were able to make contact with his mom. And she had no idea that we were worried about her and that we were trying to get a hold of her. And it was because she couldn't pay her cell phone bill. So she probably was thinking, I have these limited resources. I have to pay my rent. I have to put food on the table, maybe fill up my gas, and just didn't have enough money to pay her cell phone bill. And that cell phone bill could have changed the course of their cancer journey in so many ways. He could have become septic. He could have gotten very sick. I could have filed a child abuse report. And all she needed was some extra resources to pay that cell phone bill. So luckily, I had a resource in the community that was able to pay that bill that same day, and all was well. But I think, as simple as a cell phone bill is, it definitely illustrates how financial inequities can impact health outcomes, and how important it is to be able to assess what families need and then bring in the resources to address those needs.
Thank you for sharing that story. The impact of, exactly as you say, that cell phone bill or the opportunity to just afford gas for the car is changing
Exactly.
entire families' outcomes. Jason, I'd like to follow up on that with you, if I may, to talk about the work happening at Jordan Health, which is taking a very, very similar perspective in looking at those complex, but often comparatively small human factors that dramatically affect access and thus longitudinal well-being. And
There we go, unmuted. Before I do just a quick note. I've been watching the chat, and Suhani posed a question that actually caused me to think of something else. Suhani has some background in computer work, and it wanted to know how she could help. So I'm gonna make that more generalized for a moment. Each of us, as we look at our own, and I'll go to one of our board members said once, there are really two forms of capital. We tend to think of one form of capital, money, but there's another form of capital, social or skill capital. Each of us has to look at what do we have in the way of social or skill capital that we can share. And I can tell Suhani that in our organization, we opened up an entire division that does nothing but data mining. It's around quality, making certain we're hitting our quality metrics. It's around, the term is population management, to allow us to identify where some of the hot spots are that we need to be paying more attention to. So I would just take Suhani's question and broaden it and ask everyone, think about what you have as skills that you can bring to an organization in your community to help them with their mission. And then to your question, Brad, in terms of what we're doing, we have done a number of items. One is we've designed our primary care delivery around what we call team care. And team care is focused entirely on the patient. And if one thinks of concentric circles, immediately around the patient are clinicians and nurses. The next concentric circle are those who are key to clinical support. We have behavioral health navigators, so I greatly appreciate the conversation came about navigators, social workers, behavioral specialists, financial counselors, and they're all housed right near the clinical teams. one of the lessons we learned is that often there are things along the lines of what Claudia was saying, that there are financial pressures that are such that people are not, care falls to the bottom of the list. They're not in a position. So our financial counselors are skilled in helping them locate resources. And as I said, federally qualified health centers, we provide care without regard to ability to pay. And Claudia, one of the big messages we constantly have to hammer on for folks is that old game show. Come on down. We're going to take care of you. And in fact, one of our, the Anthony L. Jordan Health Corporation is named after the second African-American physician in Rochester, who literally took nothing or cookies or a chicken or a pie, and he treated everybody. And that's sort of the ethos we have. So from that, we began looking at what are the other barriers in the area. As I mentioned earlier, transportation has been a key barrier. In large metropolitan areas, the transportation systems are not designed so that marginalized communities have easy access to key resources. They're designed to serve the downtown, and they're designed to do so as efficiently as possible for the transit company. So that's another one. Language is another barrier that we've been addressing. We have a refugee center at one of our sites. We have 31 spoken languages at that center. Half a dozen are primary, the large populations we serve. So for us, a key is how do you communicate, just as we talked earlier about having members of communities reach out to their family, friends, and colleagues. How do we then communicate in a manner that best resonates with the different cultures we're dealing with? One of the other lessons that we've learned through that is cultures view healthcare very differently. Big shock, right? By way of one example, in one of the cultures that we work with routinely at our refugee center, the entire family comes to medical appointments, quite literally. We could have 8 to 10 people coming all at one time. At the time the building was designed, that community wasn't being served. They really joined subsequently. That location will be moving. And guess what's going to happen to the size of the exam rooms? We are going to build the building for that type of cultural interaction. So we try to get into each of the communities through our patient member directors to learn what are some of the barriers. We talked earlier about food deserts. There are really, I think in all of downtown Rochester, maybe 3 large grocery stores. All the others are in the suburbs. Everyone else has to rely on bodegas. And the bodegas don't carry fresh foods. They don't have enough traffic through them to manage that. So we're teamed up with a group in Rochester called FoodLink. It's our local food bank. They have a mobile unit that comes to our locations. As I mentioned earlier, we're going to work with them on the community health village where there will be, we're hoping, a community garden right there at the village and a permanent farmers market run by FoodLink that will actually have fresh fruits and vegetables throughout the year available. So those are some of the initiatives that we're taking. And for us, the single most critical aspect of doing so is reaching into the community and not saying to the community, this is what you need, which I think, and Kim, I would not be surprised if all of you would agree with this statement. That has been the approach that the medical system in our country has taken for years. That typically in medicine, we look at circumstances and say, this is what you as a patient or you as a community needs. We're going to turn that on its head. We're going to the community saying, what do you as a community need to improve? And the term we use very intentionally is community health, because our patients can only be as healthy as the communities in which they live are healthy, from jobs, education, food availability, and the such. So that for us has become a real touchstone, making certain we have the people we're serving at the table in the design and operation of the community health village.
I appreciate that. Thank you for sharing it. And to your point, 100% the legacy of fundamentally the paternalism that exists, frankly, but existed in larger amounts, and for so long drove the way care was set up. It wasn't, medicine was not collaborative. It was sort of dictatorial. And so to many of the points Kim was making earlier about people's opportunities to participate, and particularly to think about non-clinical patient navigators, there's a chance for them, for these non-clinical patient navigators, to be such allies and advocates because they learn the system to think about how to counter that historical paternalistic medical narrative where systems would be set up in a particular way. Following that theme about what people can do, and some conversation we had a little bit earlier, Claudia, I'd like to come back to you to ask what kind of advice you'd share to help us activate the community we have with us today in the kinds of actions people can take.
Yeah, for sure. I think when we ask people that, they think on a larger scale and feel like they have to somehow like join politics and do these large scale projects. But going back to what Jason was saying, one of the things that I've really seen lately, especially since the pandemic, and I think all of us have seen on a national level, is this idea of food insecurity. I've actually taken up cycling on the weekends, and I started noticing that when I would go for my bike ride, that there would be this long line of cars. And initially I thought, I wonder what's going on. And then my social work bulb, went off 2 seconds later, and I realized that people were lining up for food. I think if survivors think back to their own cancer journey, to everything that was impacted while they were going through treatment, to how their social aspect was impacted, their work aspect, their finances, the financial toxicity that they experienced, and just think about maybe more of this simplistic way of helping others, volunteering at their local food bank, rallying up their neighbors and friends to maybe purchase grocery cards. Again, we're having these families have to decide whether they're going to put food on the table or show up to their clinic appointment. So maybe, donating bus passes or gas cards. Those immediate needs will impact their journey so much. So families, I think people in the community just need to rally again, for that and create change on what they may think is a small scale, but can impact lives so much. But I would definitely think food insecurity. We're looking at starting a summer food program for families, similar to what schools provide when they're out of school, when kids can't go and get their free meals. We want to become a site as a hospital and provide that during the summer. And hopefully we can have that up and going for the next summer. But just encouraging people to think about how we can meet those basic needs. And I think food insecurity is a big one at the moment.
100%. And as we were saying a few minutes ago, the food insecurity in particular relates to and also drives a number of other issues in health, not just within oncology as our focus today, because it's so complicated. Thank you all, obviously, for being here today. We have but a few minutes left. And so I'd like to go around, if you're interested, and ask about closing thoughts. And a way to frame this can be, what specific takeaway would you like our audience to bring from this session? Is there an action you want them to take? Is there a specific bit of knowledge you'd like for them to bear in mind? Is there some bit of encouragement that you'd like to share as we think about survivorship and health inequities? And I'll open up the floor if you'd like to unmute and share your final bit in whatever order suits you. We're going to get risky and offer some excitement to the audience.
I'll start. I want to start by saying first, thank you to Brad, the leadership of Grit Health, for having me today. It was an honor to be a part of the panel, and to thank your conference participants, those of you who were impacted by cancer, survivors thereof, caregivers, and the like, to thank you for your participation too. We're at a moment in time, as I believe that unlike any other time before, as we are in this time where diseases are intersecting and our country is showing division across so many sectors, and unfortunately it impacts, our health, and it impacts our health in many ways. And the outcome of that in many instances are racial disparities that are happening, not only in the Black community, not only in breast cancer in the area I'm choosing to work in, but across diseases and across cancers itself. It's a hard time to, be hopeful, but there is also an opportunity for change here. Because the way I choose to look at this is that we're having such a convergence of things happening all at once, that it's kind of like almost the perfect storm, because our awareness level has been so heightened as to the challenges that are happening in different communities and that are happening in cancer in and of itself, that it presents a unique mix of opportunity for change to happen. And so while we're in this time, it's a moment too of ethical reckoning, that we can't let this time just pass, and say, we have this heightened awareness now, but then as things begin to settle down and return to whatever normal could be possibly in the future, we can't stop. We can't let just things go back to the way they are or were. It's a time where we really do have to demand the change that's needed for ourselves, for our families, for our communities. And we have to strike while the iron is hot. And so I'm really wanting to encourage all of us to, as I kind of put it before, how do we make the change? How do we make changes ourselves? How can we see ourselves as change agents? It's not always doing the biggest thing or joining the largest organization. Sometimes it's just being right where you are, blooming where you're planted, and finding the thing that you have the most influence over, or that you feel passionate or compassionate about. So whether that is advocacy, or whether that is committing to care better for yourself, or whether that is joining a community-based organization or FQHC, I would just say do it. Don't let complacency overwhelm, and don't let collective apathy stop you from doing and acting on what you may be feeling right now. The empathy you're feeling and how you're feeling involved, and you're part of this wonderful conference. Build off that momentum, and don't let collective apathy win. It's be brave enough to do it. Sometimes, the thing is just if it's a fear, or just, confronting whatever, just face it and stand it down, because you've done that probably with cancer in the past. You've probably faced one of the largest giants you'll ever face in the past, and you can do this too. And moreover, we need you. We need you to do it. We need your help. Organizations like Komen and Jason's organization and all of us on this panel, we don't do this kind of stuff by ourselves. We need you wherever you live in these United States. We need your voice. We need your efforts. We need your compassion, and we need your commitment. And so thank you so much again for having me. And I'm feeling more inspired today. Let's turn that inspiration into action.
Well, that's a fantastic way to conclude. Thank you all very much for being here. And as a finishing statement, to acknowledge we need your help, but you're plenty brave enough to do it at whatever level, within your family unit, and encouraging screenings, volunteering, reading to kids, working on food insecurity issues. There are so many avenues. So I want to thank our panelists and send some applause their way for sure, and remind all of our audience members that we have 2 other sessions starting momentarily if you'd like to join over on the GVCC20 page, and I put the direct Zoom links in the chat as well. So thank you all for being here, and thank you for sharing your expertise, and thank you attendees for your questions and support with each other.